Good morning, everyone. Today we are going to start neonatology, and in neonatology, there are a few terms which are very important to understand. My previous lecture was like in that one we covered what you can say the nutrition part. Okay, so from today we will start neonatal medicine, and after this introduction lecture, what we are going to cover is like different conditions or different. Sorry, the first thing which we are going to cover is how we deal with the newborn baby, the normal one, and then we will discuss like what can be the abnormalities and how to manage that. So let's start with a few terms. Okay, um, simply what is um, perinatal medicine? Okay, now perinatal medicine, as like in my first lecture, I told you that it is the medical care which we provide to the infant before, during, and after birth. Okay, so like this one is the medicine which is much connected with the obs and gynae, or not gynae but obs part, because it's the obstetricians who take care of the females when they get pregnant, and like all those, you can say 37 weeks to 42 weeks, if it's a mature baby, they are the one who take care of the mother and the fetus, of course. Okay, nowadays, of course, like we have a lot of sophisticated apparatuses there, ultrasonographies are there, and they keep on checking like if the fetus is abnormal or any abnormalities there or not. So um, as I already explained, what is a term infant, term term birth or term infant, or the mature one. So this is like anyone who is born from 37 weeks of fetal life to 41 weeks, right? Because after 41 weeks, from 42 weeks, it is called as post mature. So if you know, like if this is the normal one, so what is the preterm babies? Preterm babies are those who are born less than 37 weeks, simply. Okay, we call them as preterms. And of course, if there is a preterm, so there is postterm as well. So what is the postterm babies? Uh, I'm explaining these terms because guys, so that you would know like what I'm talking about. Like a postterm means you must understand that I am talking about someone who is born either at 42 weeks or more than 42 weeks of gestational life. So this is about like the timeline. Either they are born term, they are preterm, they are postterm. There is one more term which I would like to explain here, which is called as near-term babies. Okay. So near term is, by the way, the babies who are born between 35 weeks to uh, 37 weeks. Okay, we call them as preterm because uh, basically any babies who are born at 34 weeks or less than that, their lungs are not mature. But babies' lungs get mature once they cross the 34 weeks time. So 35 to 37 weeks babies, when they are born, they are preterm, by the way, but their lungs are mature. When we are going to discuss this thing in detail, then you would know like why maturity of the lung is an important thing I'm talking about. So this thing is important, and then what you can say, there is other terms which is called as SGA. Okay, so what is SGA? It is small for gestational age. Okay, and say like when there is small for gestational age, then there is LGA as well, which is basically large for gestational age. Okay, and at the same time there is AGA as well, which is you can say average for gestational age. Now, like these terms are very important to understand. What is this one? Basically, to understand this thing, you must be familiar with the charts. Okay, what I mean to say is the percentile charts. By research, what they had done, um, they had made some charts, and they know like how the babies weight is when when what you can say they are still what you can say inside the mother. Okay, so and after birth, they had designed the charts, which I show you in my one of my lecture, in which like they plot the age with height and with weight and with head circumference. That also work on the percentile. So they're like, if you don't have good concept of percentile, so just go and check that. And always and also, you can take it as a task. Okay, also check what standard deviation means. Okay, then like, because in the pediatrics, especially in neonatology, we will be talking a lot about standard deviation and this percentile lines. Okay, so you must have a good concept uh, for that. Now, basically, small for gestational age is any baby whose birth weight, okay, whose birth weight is less than 10 percentile. Okay, so these are the babies, like simply they're what you can say, they are basically beyond the two standard deviation lines. Okay, so less than 10 percentile simply. Okay, and what you can say, large for gestational age is like when their birth weight is more than 90 percentile. Okay, or you can say two standard deviations on the other side. Okay, so when it is like more than 90 percentile, so we call it as, and anyone like who lie within the two standard deviations, okay, we call them as average for gestational age. This one is not used much, okay, because these are the, you can say, the normal weight, so we don't care about that. Like we consider that thing as normal. So yeah, simply anyone whose birth weight is less than 10th percentile, or like two standard deviations from the 50 percentile, so it is called as small for gestational age. And anyone who is like more than 90 percentile, it is considered as large for gestational age. Now again, like I'll be talking about few terms, uh, like um, just okay, so now a few more terms which I would like to introduce you guys is for example, there is something called as low birth weight. Okay, so what is low birth weight? It is like when any newborn is weighing less than 2.5 kilograms, you can say, or 2500 grams. So it is considered as low birth weight. Okay, so uh, of course, like right after birth, they do weigh them, and they see like how much is the weight. So this is considered as low birth weight. Then there is a term called as VLBW, which means like very low birth weight. So it is all the fetus all the newborns who are weighing less than 1500 grams, or you can say 1.5 kilograms. And one more term is called as extremely low birth weight. Okay, so these are the newborns whose weight is less than 1 kilogram, or you can say one less than 1000 grams. So anyone, you can say, when their birth weight is less than 2500 grams, it is considered as low birth weight. Anyone whose weight is less than 1500 grams, it is very low birth weight, and anyone whose weight is less than 1000 gram, it is extremely low birth weight. So why this thing is important? Because most of the premature babies, their birth weight is very low. Okay, for example, someone who was born at very early age. Okay, like historically, nowadays, the medical services are good, so they are the babies who still can survive. But before, like many of the babies, they die when they are born at early age. Um, then there is a term called as stillbirth. Okay, um, now by the way, any fetus basically who born after completing 24 weeks of life, 24 weeks passing inside the mother or in the uterus, okay, the fetus, when it has completed 24 weeks. So that is considered as, you can say, uh, like a baby, okay, or fetus. Because before that, whenever, like for example, if a female, she's going to lose the pregnancy at, for example, 14 weeks of life, so that is considered as abortion. But if the female is going to give birth to a baby and she have completed 24 weeks, okay, so if after that, they give the birth, okay, so that is considered as a baby. So for example, if a fetus is born with no signs of life and the fetus have completed 24 weeks of pregnancy, that is called as stillbirth. Remember guys, if the fetus on birth, if they show some life, uh, signs of life, and after that they die, that is not a stillbirth. So basically these are the babies who are born dead, okay, they were alive, they were living when they were inside, but when they are born dead, okay. So born dead, or in medical terms you can say no signs of life on birth, okay, right after birth, of course. And one of the condition is what, like, provided they have completed 24 weeks of gestational life, okay. So like these are the few terms which were very important, guys, okay, like, and I wanted to make you familiar with these terms because they will come on again and again and again, okay. Okay, now remember this thing, that small for gestational age and birth weight are different things. uh, Small for gestational age deals something with, you can say, with the percentile chart, whereas low birth weight is like the way when they are born, we weigh them and then we decide, like, either it's low birth weight, either it's very low birth weight, or things like this, okay. So now, as I told you that much of this neonatology is connected with the prenatal life, okay. Like prenatal means like from the time of conception until birth, okay. So of course, like, there are many factors which play a role. For example, um, the mothers, who are smokers, they give uh, birth to the babies who have low birth weight, okay. And that's why, like, we don't recommend any female who is pregnant to smoke. Like some studies shows that, their babies weigh around 170 grams less than what the non-smokers uh, babies are. So like I talk about all these things, so I'm not going to waste time on that. Folic acid, and diabetes and hypertension and alcohol and smoking, and either they use any drugs, either they had any infections, how was their pregnancy, either there was any uneventful things, and like stuff like this. What was the age of the mother because of Down syndrome? The mothers who are more than 35 years of age, of course, there is a lot of risk to Down syndrome. By the way, like nowadays, there is a lot of, what you can say, testings are available, and prenatal diagnosis is very good nowadays. Like prenatally, now they can take even a fetus tissue, they can do genetic studies, uh, they can diagnose number of conditions, they can screen number of conditions, like Down syndrome can be screening, like can be screened. They can catch many structural abnormalities by the help of ultrasonographies. And nowadays, by the way, they are moving on to some next stage. Like for example, nowadays they are performing intrauterine fetal surgeries, like when, like they are fixing the birth defects, like before the baby is born. For example, someone have some cardiac condition, so it can be the surgery can be done when the baby is still inside the mother, okay. So of course, like advancement of these things are there. So we can do a lot of prenatal things, like one thing is called as amniocentesis. So what is amniocentesis is basically uh, before the birth of the baby, they can take the amniotic fluid from the mother. Like, amniotic fluid is the fluid like when the baby is inside the uterus. So of course it is getting all the feed from the placenta. So there is a water around the baby that is called as amniotic fluid. So we can take that, we can send it to the lab, we can perform many chromosomal studies and many things. We can also take, if we draw blood, we can simply do fetal blood sampling by taking the fetal blood directly by the help of some sophisticated type of syringe. Okay, so a lot of things are available nowadays, and ultrasonography is a very good thing because that one helps in a lot in diagnosing a lot of structural abnormalities like related to the heart, to the brain, to the face, to the kidneys. Okay, so simply a lot of prenatal diagnosis can be done by this thing. So, uh, and as I told you, like fetal surgery, they are moving on that. So now there are different factors, which basically can lead to preterm babies. There are different factors which can lead to postterm babies. There are certain factors which can lead to small for gestational age babies, and there are certain factors which can give rise to big babies or large for gestational age babies. Okay, so of course, like we are going to cover them. So before going in more detail, let me explain like quickly take you to this slide. Um, for example, okay, so okay, so you can see over here the historical perspective, though it's not like so important theoretically, but like it's quite interesting. You can say that in like before 1900s or in 1900s, um, small expect infants were not expected to live because um, not much medical care was available. Okay, so after that, what you can say, the feeding was done with tube feedings, and uh, many of the babies die because of hyaline membrane disease. Okay, so in 1940s, basically what they developed is like modernized incubators, and in 1940s, like they develop a lot of things, you can say. In 1945, the physiology of the newborn infant was written by some writer, some researcher. So then, they had done a lot of work on neonatology in 1959, 1960s, and all this time, they had done a lot of advances, you can say, in the medicine. And what they had done, like they decrease a lot of perinatal mortality. What is perinatal mortality? Simply, perinatal mortality. Uh, what is perinatal mortality? It is basically all the deaths, you can say, the stillbirths. Okay, of course, like they are born dead babies, plus deaths within first 7 days. Okay, of life. Oh, sorry, first 4 weeks. I'm sorry, not first 7 days. First 14. Sorry, first week. Yes, because it's perinatal. So remember, perinatal period is called as from the time of conception until you can say the first week of life. Then there is neonatal mortality, which is the first 1 month. So it is still births plus deaths within the 7 days. Of course, like per 1,000 of live as well as and stillbirths. Okay. Uh, so like this one is calculated. So of course, like due to recent advances in neonatology or perinatal medicine, there is decrease of perinatal mortality. There is neonatal mortality as well. Okay, and what is that? It is simply neonatal mortality is simply all the live bones, like stillbirths, they don't come in in that one. It is death of the live born infants. Okay, so all the deaths in, like, see, there is no stillbirths in this one. In live born, okay, infants, within the first 4 weeks, or you can say first 30 days, so within 4 weeks. Okay, so, and of course, like, per 1000 of live births. Okay, so that is called as neonatal mortality. So perinatal covers the stillbirths, whereas neonatal, it doesn't cover the stillbirths. So simply, like, there is a lot of advances, and they work a lot on surfactants and many investigations. There were many formula milks and many other incubators and mechanical ventilation. The mortality rate decreased a lot. And say, like, in 1971 to 1989, there was again a lot of advances, you can say. The ECMO, or extracorporeal membrane oxygenation, this is a machine which can provide someone with oxygen when their lungs are not working. So something very sophisticated, very expensive, and very life-saving type of thing. Okay, so like someone who cannot breathe, by the way, they put them on ventilators. But someone, for example, when the lungs are damaged, your lungs cannot function properly. Uh, your lungs cannot exchange the oxygen. So what you will do, you can provide them with ECMO, which can provide the oxygen, which can, like, the blood passes through this machine and get oxygenated and then put back to the body. So a lot of things, they are formed. So glucocorticoids were introduced in 1970s to 1990s for lung maturation, and that's what we do. Like, anyone who is born for less than 34 weeks of pregnancy, when their lungs are not functioning, we give them steroid injections. And you can see, like, a lot of genetic counseling, testing, and many things were introduced, like the modern incubators they are showing. So the baby named Rumaisa weighed 244 grams and was the size of a mobile phone when she was delivered 14 weeks early by C-section at Chicago Loyola University Hospital. Smallest baby survived in the world was like this one. Okay, uh, so now, again, like, this one is all the things which I already explained. What is a neonate? What is a newborn? Early neonate or late neonate, or perinatal period for the first 7 day of life. Okay, what is term, preterm, postterm? Like the same thing which I already explained you. Okay, so this one is like the near term. I added one more term here. So again, this is the definition of live birth by WHO. Simply, guys. Uh, if you're interested, of course, you can pause it over here and you can give it a look. But I will go. Uh, okay, these things I already explained you. Okay, and this thing I already explained you. Um, and this is, they're talking about birth weight versus gestational age, of course. And now, before going to high risk pregnancy, like, I would like to show you something. Okay, this one is basically a chart called as Duvet's Ballard exam for gestational age. And nowadays, a lot of sophisticated things are there. So what happened is, uh, we can do simply one ultrasonography examination. Okay, for example, like, it's not like this, that when the females, they get pregnant, they all know, like, what is the date they get pregnant. Sometimes they are unsure about the date. So what the doctors do, they can do a dating ultrasound. Like, by ultrasound, you can see, like, how much development of the fetus is already done. Okay, like, either it's organogenesis is going on, or the heartbeat is there or not. And there are many things. Okay, what is the size of the femur, what is the distance between, what is the biparital distance, or there are different measurements which radiologists do, and they can exactly tell, this is the age of the fetus. But before, like, of course, like, sometimes when the babies are born and the mothers are not sure, uh, like, at what time they get pregnant, so they can check the posture and all these things, in the babies, and they can give points, and based on this, they can tell you what is the gestational age. Okay, so basically, you could say this is a system which is used for assessment of delivery, and by the help, like what they see is simply physical maturity. They check the plantar crease, okay, uh, and all these things. Okay, so when someone is getting higher score, it means higher maturity. Okay, and someone is getting like lower score, it means like what you can say, a lower maturity. But nowadays, that is not used much. Newborn reflexes, we already talk about that. But um, okay, so whenever a baby is born, there is a lot of what you can say features which we can see on the baby, and we can decide like either the baby is born at term, or the baby is not born at term. Okay, or like it's a premature baby. So like I would like to discuss some other thing here right now in this lecture. I'm going towards that, and that is about you can say abnormalities of the gestational age and size. Okay, so you can say it is abnormalities, okay, of GA, gestational age, or and size. Okay, now in this one, see what are the things which we can face, for example, in these patient patients. Um, the first one is we were talking about preterm babies, right? So as you know, what is preterm babies? All the babies who are born for less than 37 weeks of gestational age. Okay. Now, what are the causes of this preterm babies? What are the causes of preterm babies? That's a very important point, because um, wait, okay, what are the causes of this preterm babies is like the most common cause you can say is unknown. Okay, because prematurity is very common, by the way. Many babies, they are born premature, and when you start checking or exploring the causes, so basically you cannot find any cause. So that's why the most important cause of preterm babies is unknown, and that's why we call it as spontaneous. Spontaneous, like it's a simple English word, and which means uh, like spontaneously it like the labor started and the baby came. Okay, so you cannot found anything. But when you can found some causes in the patients, okay, so there could be many. Okay, we divide them into uh, you can say three major conditions. One is called as maternal causes. Okay, um, one can be fetal causes. Okay, and one can be um, pregnancy issues, you can say. Okay, pregnancy issues. I like to I'm just making the terms broader, just to like make you understand what are the things you can consider in the patients. Okay, so in maternal causes, guys, hypertension. Okay, hypertension is such a thing. It can give rise to prematurity. It can give rise to less birth weight and many things. Okay, so uh, again, diabetes mellitus is one of the things which can behave in many ways. It can cause prematurity. It can cause, of course, large for gestational age, like big babies. Okay, so in mother, hypertension, diabetes, or if the mother have some cardiac or you can say renal disorder. Okay, uh, these are all the causes which mother may have, and they can give to premature babies. In the fetus, one of the fetal cause which is very 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 important is twin pregnancy. Okay, you can say multiple pregnancy. Why? Because it could be triplets. Okay, so multiple pregnancies, like all the mothers who are pregnant, and they are carrying like more than one fetus, there are higher chances that the labor will start like prematurely. Okay. Other thing, like if they have any congenital anomaly, uh, anomaly. Okay, so like simply the baby have some congenital anomaly, and that's the reason like they can have what you can say premature labor. Macrosomia, macrosomia is what you can say big babies. Okay, simply see these are disconnected. Mother have diabetes, it will give rise to big babies, and which can lead to prematurity. Okay. uh, okay, there are others as well, for example fetal infection, though not so important, but many other causes can be there. Okay, now if we will talk about the pregnancy issues, it could be anything related to placenta, it could be anything related to your socioeconomic problems, or like your personal reasons. Okay, for example, if we will talk about the placental issues, it could be, there is a condition called as placenta previa. What is this one? In which the placenta is not at its normal site. Like the placenta is at the top of the uterus. Okay, so if the placenta is not at the normal site, rather it is attached somewhere else at the wrong position. So placental previa is when the placenta is located downwards towards the opening of the uterus from where the baby have to come out. So many of the patients have placenta previa, and if it is covering the outlet completely, so we have to perform C-section in these patients. Okay, uh, so placenta previa is one of the cause. Uterine abnormalities can cause premature labor, as well as infection, any kind of infection in mother. Okay, and especially the females who have previous history of preterm labor. Okay, so any female who have given birth to a baby prematurely before, they have higher chances that they are going to give premature baby birth at this time as well. And there are some other factors which can cause prematurity, like smoking. These factors will come, like when you will study OBS, you will find that these factors are almost everywhere. Alcohol, drug abusers, okay, like the exotic drug abusers, and stress. You can say the age, for example, if the mother is, you can say big age, like or very very old, or like more than 35, 40s, like this. Okay, late pregnancy, simply you can say. So uh, all these conditions can lead to what you can say premature labor. And now guys, remember, like the most important cause, like many of the times, most of the time, it is unknown, without any prior medical condition. What we found is like the baby is born prematurely. Okay, so why we don't want premature babies is because they can cause a lot of, they may have a lot of problems. For example, their lungs are not mature. When their lungs are not mature, they may have respiratory distress syndrome. Okay, uh, some of the time, like on birth, they cannot breathe properly. It is called as apnea of newborn. Okay, we will discuss all these conditions, of course, in the coming lectures. uh, Many of these babies, they can have chronic lung diseases. Okay, uh, then it like of course, like when the babies are premature, we face a lot of feeding difficulties. Okay, sometimes we have to put them in incubator for a long period of time. Okay, and of course, like it's hard to it's difficult to, of course, manage a term baby and a preterm baby, and especially the babies who are born in less than 34 weeks of time. Okay, so like if they are like, if the prematurity is too much, like if they are born, for example, at 28, 39, 29, 30, 31 weeks, it's hard to manage them. So as soon as they get mature, the things become easy to manage. So when they are born, they may have hypocalcemia. Okay, they may have hypoglycemia. Again, like this is connected, The mothers, who are diabetes mellitus, they have big babies. They have increased chances of getting hypoglycemia after birth, and they may have hypothermia, and that's why we put them in incubators to maintain their temperature. They may have anemia. They may have jaundice. Okay, and even like uh, when they have jaundice, their jaundice is prolonged. Okay, like there is one type of jaundice which we'll be discussing in coming days, that is basically called as what you can say physiological jaundice, which occurs in almost all the babies. So even the physiological jaundice is prolonged in premature babies. It is like in mature babies, if it lasts like 3 to 4 days, in premature babies it lasts like for 1 week or more than that, for example. Okay. Then there is like their retina is not mature, so sometimes they have retinopathy. So it is called as retinopathy of newborn. Okay, and their brain and their skull bones are so weak, and it's like still developing. So they may have intracranial hemorrhage, or like during the birth trauma maybe, or intraventricular hemorrhage. Like what is like this ventricles is like inside the brains there is lateral ventricles and third ventricle and fourth ventricle. And what happened is uh, there can be bleeding in that ventricles, and these are the ventricles, by the way, which give which where the CSF is formed. Okay, so these things can be there. Patent ductus arteriosus. When we will study cardiology, you will know it's a type of a congenital, what you can say, problem. So anyhow, like this one is like you can say the introduction, the problem of prematurity, and of course like you get familiar with new terms. Okay, what is RDS, what is these terms, and of course when we will discuss in coming days these terms more, so you would have better understanding. Okay, uh, we were discussing preterm babies, now we will discuss postterm babies. Okay, of course like postterm babies are those who are born greater than 42 weeks. Okay, and uh, one of the identification points for these babies, guys, when they are born is like they have leathery skin. Okay, when the babies are born, they are their skin is covered with creamish type of you can say material. Okay, and when the babies are post mature, when you feel their skin, you will find that their nails are long, and their what you can say their skin feel like more leatherish. Okay, and one very important thing which will again keep on coming in the coming lectures again and again, it is called as meconium. Okay, meconium, meconium. So what is meconium is basically um, uh, it's the first stool of the baby. Okay, stool means feces. So what happened? Basically, as soon as the baby is inside mother, so from where they are taking their requirements, they are taking the requirements from the placental blood. Okay, they are taking their glucose from mother. They are taking their oxygen from mother, and they are in they are in sterile environment. They are not eating anything. Okay, because they are inside the womb and they are surrounded by amniotic fluid. So basically what happened in these babies is if there is post maturity, uh, sometime uh, before birth, they can pass their first stool or they can pass their first feces inside the mother, and it is greenish in color. And that feces, when they pass, uh, amniotic fluid, which is the fluid surrounding the baby, is clear. But once they pass the stool or meconium, it stained as green color. We call it as meconium staining. Okay, it is called as meconium staining. So these are the babies who have meconium staining. Not all, maybe many of the post-mature babies, they may have meconium staining. And whenever like they like the amniotic fluid is stained with meconium, there it can give rise to different problems, like the babies can like this meconium fluid can go inside their lungs, okay, and can cause something called as meconium aspiration syndrome, okay. Like, see, when the babies are born, they take their first breath like after coming out from the uterus, or so as soon as their lungs expand, what the doctors do is like they they suck all the fluid inside their mouth, and the fluid which is present in the lungs is basically absorbed by the lymphatics. But in post-mature babies, when they pass the first stool inside while they are still inside the mother, they may pass the first stool, and because now there is, like, it's not clear fluid, but it is the meconium which is there, though it is sterile, there is no bacteria, but still it is something which is not good for the lungs, and it can cause some irritation to the lungs. So that's why they have this thing. So their skin feel leathery, they have meconium staining, they may have, not all the post mature babies. So what are the causes, guys? Again, the most of the causes are unknown, okay. Most of the time when the babies, mm, they are not, you can say the labor has not started and the babies are not born until 42 weeks, most of the times you cannot do, if you fail to find the cause, so it is unknown causes, okay. So one of the causes, the first pregnancies, the mothers in their first pregnancies, the labor doesn't start too early, rather it takes some time, okay. So there is higher chances that the first mothers, okay, uh, the females at their first baby, they may go into post maturity or post-term labor. And anyone who have history of previous post-term labor, this is one of the cause. And what else can be the cause is mm, I don't think so, like there's any cause. Yes, genetic factors can be there, but okay. We will not discuss that right now. Okay, problems of post maturity, guys. This thing is important. Now, there can be many problems of post maturity. First of all, think like this, that the baby is overstaying, is getting bigger, bigger, and bigger. So, a lot of problems it will create while at the time of birth, during the time of labor. So, there is increased chances of stillbirth, okay, in these babies. And there will be they have increased birth weight, okay, that makes sense, of course. And uh, there is something called as post maturity syndrome. What is this one is, like because they are getting bigger and bigger inside, so there is a time when the placenta cannot properly support, like provide the blood which is required with the growing fetus inside. So uh, it can cause some problem with the development, okay. So we call it as post maturity syndrome, and that's the reason the obstetrician who is dealing with the patient who is pregnant, they keep on doing ultrasonography. And one of the tests they do is called as Doppler ultrasound. What they do, they keep on checking the blood flow in the umbilical cord, or you can say the arteries and the veins, okay. So any female uh, who is going into post maturity, and when the doctors notice that now uh, not even just post maturity, for example, there's a female at 37 weeks, the labor is not started, so if the blood flows through the arteries is good, it means like there's nothing to worry about. But for example, the blood flows through the umbilical vessels is now getting compromised, so for sure it means like it can cause some developmental problem. So that's the reason they can decide like either to go for the surgery or to give some drugs to start the labor. Anyhow, OPS, okay. And of course, meconium aspiration syndrome. In case like the baby have passed, um, what you can say, the first stool inside the mother. So meconium aspiration syndrome, MAS, okay, it can also occur. So guys, see, like when the baby is premature, okay, they may have respiratory distress syndrome, they may have apnea of newborn, they may have chronic lung diseases, but when the babies are post-mature, they have meconium aspiration syndrome if they pass the first stool inside the mother. Okay. So that's about preterm and postterm. Then what was the third thing is small for gestational age. As you know, like these are the babies in which like their weight, birth weight is falling below the 10th percentile. So uh, we whenever like this is the condition, like someone is having low birth weight, we on examination what we see, what we check, by the way, a very important point, guys. We check like either there is head sparing or there is no head sparing, or you can say there is symmetric. What I mean to say, like the baby is small, right? So if you can say all the body is small but the head is of normal size, the head circumference is normal, so we also call it as asymmetric. Okay. Why? Because see, there is asymmetry now. The the body is compromised, is small, but the head is normal size. So whenever it is asymmetric type, you can say it is late onset, or you can say like this growth arrest occurred late in the pregnancy, or you can say towards the end of the pregnancy. Okay. But whenever it is symmetric type, like, or simply you can say the body as well as the head, both of them, they are like stunted growth is there. So we it means like it is early onset. Okay, like it started early in the pregnancy, early onset. Well, now there are different causes of early onset as well as late onset. Okay. um, okay, so we can discuss about the causes of, you can say, small for gestational age causes. Okay, talking about the causes for small for gestational age, there are extrinsic causes as well as there is intrinsic causes. Extrinsic means, the factors which can influence from outside, like outside the fetus. Okay, like placental insufficiency. What it means, like the placenta is not supplying enough blood, which is required by the baby. For example, if the mother is not taking proper nutrition or poor nutrition. Okay. For example, if the mother has hypertension, that's what I told you, it will keep on coming again and again. For example, if there was twin pregnancy or multiple pregnancies or triplet, okay, multiple pregnancies, okay. Sorry, not twin, like multiple, like the mother is getting pregnant again and again. And there are many drugs which play some role. You can say, like there is a list of drugs. Alcohol for sure, and smoking for sure. Okay, these are the factors which come almost everywhere. Intrinsic causes, of course, like you can say, um, which basically within the fetus or which affect the fetus. You can say if the mother have infections like torch infections. I talk about that thing. Any infection, other than torch, like maternal infections, which can affect the baby, the fetus. Okay, many genetic syndromes. You like when we discuss that, of course, you would know there are many Down, Turner, Klinefelter, and so on and so forth. And some of the time it is idiopathic as well. Like we fail to found any cause. Like what is the thing which is which have caused this? You can say small for gestational age. Okay. And why we are concerned with this thing? What can be the problems which can arise due to this small for gestational age? Is again there is increased chances of hypoglycemia upon birth. Okay, again hypocalcemia upon birth, hypothermia on birth, and increased chances of prolonged jaundice or jaundice simply, and increased chances of patent ductus arteriosus. Okay, so any of these things can occur. Okay, so the last one is the large for gestational age. Of course, these are the babies whose weight is more than 90 percentile. Very easy to remember, guys. What are the causes? Okay, and what should be the first cause? Remember one thing, it's large baby. So diabetes mellitus should come on the first one. Okay, now there is many races or racial factors, racial factors racial factors. For example, there are races, who are big, their babies are also big, or you can say there are families who are big. Or so we can write familial factors, like big families or big people, they have big babies. Small people, they have small babies, of course. Okay, this thing, and any mother who have high BMI, like their body mass index is too much. Okay, uh, and there are certain syndromes, by the way, okay, in which the babies are born big. Okay, not so important, by the way. Okay, so this thing, and now what can be the problems, or simply what are the things, these, what you can say, large for gestational babies can cause. Now think about, the baby is big, so start from at the time of birth. What will happen? uh, the baby will find it difficult to come out from the mother if it's a spontaneous vaginal delivery. So there is increased chances of birth trauma, which can be anything. One thing is called as shoulder dystocia, in which, like, sometimes, their bone can get fractured. Sometimes their shoulder can stuck. Sometimes, there is damage to the brachial plexus. So any type of things can occur. Meconium aspiration, if it's a postterm baby with a big baby and they have passed the first stool inside the mother, they can cause respiratory distress syndrome. Transient tachypnea of newborn. Transient for a short time. Tachypnea, increased rate of breathing of newborn, like which occurs in newborn. Increased chances of jaundice. They will be having polycythemia. What is polycythemia? Increase RBC's numbers in their body, and again they can go into hypoglycemia. This thing is connected with this. Okay, diabetes mellitus mother babies are at risk of developing hypoglycemia, as well as hypocalcemia. Okay, so that's all about, you can say, uh, like, all about the babies, large for gestational age, small for gestational age. Okay, uh, and a lot of advances, and a lot of, so we are discussing this thing because, in the next lecture, what we will starting discussing is what happened when the baby is born. Okay, and what we do right after birth. Um, I can introduce a few things about that now. Um, okay, here, like, maybe I will not write everything, but of course, like, I will explain a lot of things. Okay, because the time is short, you can say, and like, I will be saying more and writing less, you can say. Okay, like, when it's a fetus, the lungs are filled with fluid. What kind of fluid? Of course, like, uh, you can say, adaptations, which should be done to extrauterine life. Okay, like when they come out. Uterine life is when they're inside. Extrauterine when they come out. Okay, so the lungs are filled with fluid when they are inside the mother, and if you know, like when they are inside the mother, they are like in less oxygen environment. Okay, because they are taking the oxygen from the mother, and mother lungs are the one which are oxygenating, and as soon as the blood will reach the baby, uh, it's not a very new type of oxygen because it's circulating from the mother blood. So when they come out, they come in oxygen rich environment because now they are getting first hand oxygen, their lungs are working. Okay, so they are living in, you can say, less oxygen, comparatively less oxygen environment. Okay, when they're inside. So this is one of the thing, you can say. Plus, there are many other things I will show you now. For example, like if you know about the fetal life, I can show you here. I can bring it from one side, just to show you how the things work. You can see over here. Okay, you can see what are the changes you can see, which are there. This is ductus arteriosus, and uh, this is the vessels, okay, from where you can say the oxygenated blood is coming from the placenta in umbilical vein, and the umbilical vein is going to the liver, okay, and this connection is called as ductus venosus. And after birth, basically, this one closes. Why? Because the liver, see, like the baby is getting blood which is already, you can say, filtered by the mother liver, and the blood is diverted basically in the fetus to the areas where the blood is more needed, not the liver is not functioning much, lungs are not functioning much, heart is functioning, and brain is functioning. Like brain is the one which need more development. So ductus venosus is a connection between umbilical vein and inferior vena cava. Upon birth, this all channel close and the portal circulation basically pass from the liver and go into the inferior vena cava. See, the oxygenated blood um, enters the right atrium, and from right atrium it goes into the left atrium, as well as there is an opening which is called as the septal, which is a communication between the right atrium and the left atrium. Because at this stage we don't want the blood to pass through the lungs because it's already oxygenated blood. So the blood from right atrium can directly go into the left atrium, and the rest of the blood which is going through the left right ventricle, okay, is going to the pulmonary arteries, and from there basically the blood, instead of going to the lungs, it is shunting to the aorta, you can see over here, by a communication called as ductus arteriosus. Okay, so ductus venosus is a communication between umbilical vein and the inferior vena cava. Ductus arteriosus is a communication between pulmonary artery and the aorta. Okay, so after the birth, this one should closed. When this after the birth, when this thing stay open, we call it as PDA, patent ductus arteriosus. And simply after that, once the blood will enter into the aorta, it is supplied to all the body. And the deoxygenated blood, by the help of two umbilical arteries, uh, basically go back to the mother placenta. And that's why right after birth, what they do is like they examine the placenta for any defects, and they examine like the baby should be having, the umbilical cord should be having like three vessels, two umbilical arteries and one umbilical vein. Okay, so that's all about what you can say that intrauterine circulation. And there is a lot of changes which occur after what you can say after birth. Okay, so of course, like that thing, you can say we will discuss in the next lecture. Okay, so as I show you how the blood is shunted through two different channels, and they should be closed after the baby is born. Okay, as soon as the lungs started expanding. So on average, you can say the first breath occurs around 6 seconds after the delivery. Within 6 seconds on an average, which means like some babies they can take the breath after 2 seconds, some take around after 10 seconds. Okay, but the most of the babies, on an average, they take the first breath after 6 seconds, and as soon as their lungs started expanding, uh, the blood is shunted towards the lung, and they what you can say, they get oxygenated. And by 30 seconds, the regular breathing it started in the newborn. Okay. So anyhow, guys, thank you so much. Like in the next lecture, of course, we will start with other topics related to the neonates. Okay.